The next session is on pancreatectomy. The first talk is by Dr. Ravish sir. Total pancreatectomy, feasibility in Indian scenario.
Good morning. I think it's a very easy question. Feasible, yes, no. The answer is yes. It is feasible. I will just give you just two messages through this talk. One is, how will we counsel somebody, or how do we prepare somebody for a total pancreatectomy? The second is, under what circumstances are we doing total pancreatectomy in India? For what diagnosis are we doing? What are the centers? Not very much on outcome, but at least what are we doing? And is there anything missing from our publications? So, total pancreatectomy primarily done under 4 situations. The first is for benign disease, chronic pancreatitis, hereditary pancreatitis, sometimes where it's done prophylactically for trauma. Then for neoplasms, and these are either primarily IPMN or neuroendocrine and carcinoma pancreas. So these often are planned. The second situation is when during an operation a decision is made to do it, to convert a pancreatic duodenectomy or a distal pancreatectomy to a total pancreatectomy. So one sometimes is when we expect that the patients get a high risk for major complications during the operation, or the tumor extends beyond. And second situation is in a post-op situation where maybe a lot of sepsis is just not going to, nothing is going to settle down unless the total pancreas is removed, or over time somebody develops a second neoplasm. So a planned pancreatectomy, a conversion total pancreatectomy, and a completion pancreatectomy. That was the theory part. The theory part is over. How do we counsel, or how do we prepare someone in the Indian scenario? The West is completely different. In the Indian scenario, how will you prepare someone for a total pancreatectomy? First thing is, it's expensive. Not just the operation, post-op care is expensive. And it costs anywhere a minimum of 8,000 to 10,000 rupees a month. So before we counsel someone and tell someone or offer someone a total pancreatectomy, must be aware that it causes a problem. Just as an example, one of the patients we did cannot read. We did a total pancreatectomy, and she has no clue how much insulin to take. So our people will show her an insulin syringe and say, up till this much you must take insulin. And she doesn't take it, and her sugars are all wavered. So the patient has to be ready, his wallet has to be ready. Unfortunately, I think in India, auto islet cell transplantation is not really popular, so we leave that for the moment. Introduce them to the endocrinologist beforehand, any endocrinologist whom they will follow up. Before the operation itself, let them meet and let them get to know each other. And pre-splenectomy vaccination. I'll just skip this. So I asked our endocrinologist, what will you do when you see someone, or what will you counsel them before? And this is what they say. Insulin pumps are available in India. They cost about 6.5 lakhs, fairly long lasting, but an insulin pump costs about 25,000 rupees a month. So it's not for everybody. Surprisingly, the insulin need is not that they will require, we all assume that they will require large volumes of insulin, but they don't. Why is that? Why don't they require 30, 40 units of insulin per meal?
No.
Very good. There's no glucagon. No glucagon is being secreted, and so the insulin requirements are much less. On an average, what we have found is it's about 0.5 units per kg per day. So most people will require about 30 units of insulin per day. Some of it is, 30% of that is given as long lasting, and the rest are given as short acting along with meals. Our endocrinologists ask them to check bioglucometer and check sugars at least twice a week, one fasting and 3 times after meals. We know glucose fluctuations are higher. We also know that some of them, some indications, for example, like chronic pancreatitis and neuroendocrine tumor may live long. And so we need to check for other complications. Generally, we have found that about 25,000 units of lipase per meal is adequate. Some of the other publications from India seem to say that our patients need about 40,000 units per meal. There is potential for fat-soluble vitamin deficiencies. And for vitamin D, we just give injection prophylactically. Vitamin A is not given prophylactically, but we look for either symptoms or signs and only then given. And that is how the endocrinologist likes to follow up our patients. So importantly, sugar control, aggressive sugar control, and pancreatic enzymes, vitamins, don't forget vitamins, and follow up. Keeping that in mind, the topic really is what is happening in India. And most publications are as case reports. So there are some, and interestingly, a lot of them are as supplements. So they were presented at some conferences but never ever published. And so the first one I think is from AIM, one of them is from AIMS. Second one is part of a different, the emphasis was something else, but that had some total I think 7 patients of total pancreatitis with total pancreatectomy in that. Dr. Senthilnathan is here. Laparoscopic, so it's obviously possible, minimally invasive. And again, Dr. Biju told me you must include the NIM series. So there is some few papers from other places as well. So as part of the IHPBA last year, IHPBA conference, Dr. Ajay Mandal was asked to speak on this topic. And he said he wrote to practically all the large volume centers in the country and asked them, what are your series? And so the largest series is from Tata, and 30 patients, and primarily most of them adenocarcinoma seems to be the largest, and with varying survival. Majority of death obviously is because of recurrence, especially in the adenocarcinoma group, but 5 died due to metabolic complications. So I think this is something we don't see in other operations. So we need to treat total pancreatectomy a little differently from other operations. This is Dr. Punithar's, his own personal experience. So we again and again keep coming back. It's either cancer or neuroendocrine or cystic tumor. And this is his experience. Another experience, Dr. SN, IPMN, chronic pancreatitis, adenocarcinoma. Most people seem to think that these people live well, that unlike what, it's not something to be terribly scared of. An apancreatic state is scary, but a lot of patients probably also are able to manage that. So don't deny someone a total pancreatectomy based on our own inhibitions. This is Dr. Ajay Mandal's, his own personal series where he had 5 patients. So most, I think 5, 10, 12, this seems to be most series in India. AIG published their series again as a supplement. It came out I think last year, where they had 7 patients and with reasonable follow-up. I'll just give you the CMC experience. We've had 14 patients over the past 10 years. That's the mean age. So out of the 6 patients with IPMN who underwent total pancreatectomy, 5 had concomitant malignancy. Neuroendocrine tumors, 3, out of which 1 was a neuroendocrine carcinoma, and 5 for adenocarcinoma. Interestingly, 28% had delayed gastric emptying. You would think without a pancreas, there would be no delayed gastric emptying, but a quarter of them had delayed gastric emptying. And mean stay was longer than usual. But surprisingly for me, prehabilitation and post-op care is something we really pride ourselves on, that we do that well. That 20% of our patients died in the immediate post-op period. And the first one, sepsis and respiratory failure. This patient had coronary artery disease as well, I think. The third one was very, very unfortunate. We're not very sure. Patient's sugars went up dramatically one day and had hypertension, but not a very significant hypertension. But soon after that, the liver function went off completely, developed all features of ischemic. I mean, looked very much like an ischemic hepatitis, though there was not much hypertension, and succumbed to that. And I suspect the patient in the middle was for sepsis. So, in our hands, we have a lot to improve for total pancreatectomy. And what we don't have in this country is just to take total pancreatectomy, analyze the patients, and what has happened to them. We have no outcomes for total pancreatectomy. Total pancreatectomy is clubbed along with a lot of other conditions, but just as an operation or just as a treatment modality, we don't have outcomes for that. So, total pancreatectomy done, an indication being, a need for total pancreatectomy being done during the operation is not a good thing. So, did we think about it preoperatively? Did we plan for it preoperatively? What we also don't seem to have is, was it an R0 resection? A frozen section showed that there are disease and we go on extending it. But was it worthwhile? Was it needed in the first place? We don't have that data. We don't have data on nodal disease. We know that nodal disease has a significant outcome measure for total pancreatectomy. So whichever of you among the audience here is now going to publish their outcomes of total pancreatectomy, please talk about nodal disease as well. Survival seems to be, everybody likes to talk about the numbers, but we don't have much on survival after total pancreatectomy in India. Then of course, quality of life indications, maybe financial costs. Often excision comes along with excision of other organs. So one of our patients who died, one had a colonic excision in addition, and a second patient had a hysterectomy along with the total pancreatectomy. So maybe that was a wrong decision from our point of view. So, but just talk about, was there anything else excised along with that? And for benign disease in the Indian scenario, what are the long-term complications? Is the sugar control adequate? Are our people able to survive, able to do well without metabolic complications? So thank you. Just to summarize, the treatment for before doing a total pancreatectomy, we really need to have the patient agree for it. The patient should be committed to it. Please discuss what a total pancreatectomy means in some detail with the patient. Get the patient ready for it. There's a significant financial issue there. It is not all hunky-dory, but it's not as bad as we all think it. I mean, in my mind, there was always a block. I would always hesitate before offering someone that. It's not that bad, but all the same, there are unexpected complications. So an educated patient is always much better than someone who's not gone through it. Thank you.
Thank you, sir. That's a wonderful talk. Just a few comments. Most of the total pancreatectomies in the Indian setting are done for malignant indications, as you rightly projected. So, as you rightly mentioned about preparing the patient for total pancreatectomy, most of these decisions are made on table based on frozen section. So, we should also work out on whether, in case a total pancreatectomy is needed, what are we going to do about it, and things like that. With regards to a benign indication like chronic pancreatitis, I would still say I'll take it with a pinch of salt, because we hardly refer much of our patients to surgical total pancreatectomies. Good armamentarium of pharmacological measures are there, and non-pharmacological measures like TENS and scrambler therapy are all evolving. So we will require less and less of total pancreatectomies for benign indications is my thought on that.
Any questions? Yeah.
Good morning, sir. Sir, what type of reconstruction do you use, sir? You have indicated that your DG rate is 28%. Any difference in using a single loop versus a row and Y, or doing a poly or crinoline type where we anastomose the gastric stump as a whole to the jejunum, or you close the gastric stump and make a new incision at the stump and make an anastomosis?
So I'm not sure what we have followed, but we have just followed, as far as I remember, we've done all of them like all regular Whipples. We've just done hip gedge and taken the loop up to do a posterior GJ.
So single loop is...
Single loop, yes.
Thank you.
Probably Dr. Ravish wanted to convey that in total pancreatectomy, gastric anastomosis you don't think, because you have a mountain of problems to handle. Is it correct?
Sorry, I didn't get.
No, you have a mountain of problems to handle after total pancreatectomy, and you do not put your brain on how we do gastric anastomosis. Correct?
Okay.
Yeah, very good talk, Mac. One comment and one question. The comment is, total pancreatectomy is one procedure which we no need to afraid of. If there is a need, whether it's for benign or for malignant or for neuroendocrine indications, I think we should be prepared to do that one, because post-operatively, if you have a treatment plan, follow-up plan, patients live long enough, patients have a good quality of life. That's what in our limited, but we are forced to do a pancreatectomy. That's what our experience also have shown. That's my comment. My question is, what's your take on total pancreatectomy for benign, say CCP, with a subsequent islet cell transplant? Because there are a few centers, which, especially from Western literature, which we have not been doing that one. What is the reason where we see a lot of tropical pancreatitis, but to my knowledge, no center in India does a total pancreatectomy with islet cell transplant? Probably that will answer to a lot of questions which we...
So I'm not aware of anybody in the country doing islet cell transplants. Is anybody doing? Sorry.
No, there are centers in India, sir.
India,
Yeah,
nobody. To
yes,
my
yeah.
knowledge, is nobody. The West as well, from whatever limited talks I've had, it's done prophylactically. You've got the genetic, you've got the gene, especially in children, because children the penetration is much higher. So we've identified features of hereditary pancreatitis. They undergo a total pancreatectomy straight away and islet cell. The advantage is that the pancreas function is still good. They are good for, the islet cell number is good, and it's done. So it is done. I know I've heard people talk about being done for intractable pain and so on, but I'm not aware of anybody here having an experience in that.
Just to add to actually what Professor Biju was mentioning too, yes, it's a relatively, everybody thinks that there will be no pancreatic anastomosis and it will be an easy procedure, but the indications for which it's done, most of the times the surgery is difficult than what you imagine. Like technically everybody thinks that total pancreatectomy is easy, but there is a significant risk of gastric congestion, as Professor Biju mentioned, and sometimes you have to salvage the stomach, sometimes you have to do a near total gastrectomy. So it's not as easy as it is even intraoperatively. As you said, the perioperative mortality and morbidity can be very, very significant, and there are long-term complications with metabolic, and a lot of things come in. Most of our patients are financially probably are not ready to have that burden of around 20,000 per month of exocrine endocrine replacement. So yes, it has to be done very, very carefully. In my practice, I am very conservative in offering that. Even if I can preserve a small 3 centimeter stump of a pancreas, it will take care of a brittle diabetes or to a certain extent. And we make every effort to actually preserve whatever pancreas we can in some of the indications where some other center might do a total pancreatectomy. That is one of the reasons, in spite of nearly 3,000 pancreatic resections, only around 30-35 total pancreatectomies have been performed. So yes, we are a little conservative in offering that. And mind you that technically it may be easy, but most of the times it is not, and the morbidity and mortality is significant. Thank you.
And just to be aware that many times this is also associated with portal vein reconstructions and so on. So that adds to the
One of my
tension.
classmates in Australia is actually doing, but he does it, as Ravish said, a gene study present and does a prophylactic total pancreatectomy for hereditary pancreatitis and islet cell. But in the West, I know they really have to earn for the operation. They have to be opioid dependent before they are